Good morning to everyone. I'm Luciano Saso. I'm a professor of the Faculty of Pharmacy and Medicine at Sapienza, University of Rome in Italy. I'm also a member of the Executive Committee of the M8 Alliance. The M8 Alliance is the backbone of the World Health Summit and always paid a very high attention to the topic of migration and health. We organized several sessions here in Berlin on the World Health Summit, other sessions at the regional meetings of the World Health Summit in several continents. We organized expert meetings in Rome, so smaller meetings with experts from all over the world gathering in Rome in 2017, 2018, and 2019. For me as Italian, the topic of migration and health has been always very important because Italians, as you know, have been emigrating everywhere for a long time in very difficult conditions, but not as difficult as the ones that the migrants face today to reach Europe and other areas of the world. So I feel really this moral imperative to try to raise attention to the topic and to keep the topic important in the World Health Summits. After COVID, we did not stop. We started a series of webinars. I encourage you to visit the page that we have on the website of the World Health Summit, where we gather all the programs of the webinars that we did in the last 3 years. They're really very important, very relevant, with speakers of a high level. And, that's also, there are many information, also some publications are there, came out of some of these events, so I really encourage you to visit this webpage. Today, to address the topic that we chose for the session today, we have a panel of distinguished speakers. We have Ozge Karadak. She's a professor of public health at the School of Medicine of BAU in the University of Istanbul. We have Selma Karabey. She's a professor of public health at Istanbul University Medical Faculty. Nuhad Yazbik Dumit, she's a professor of nursing at the Hariri School of Nursing at the American University of Beirut. Rabin Pasha is a founder and CEO of Social Development Horizons in the US. We have Paul Spiegel, is the director of the Center for Humanitarian Health at Johns Hopkins University. Paul is online. Thank you very much, Paul, for being with us very early for him in the US at the moment. We have Ivory Horn. She's the director of the Health Equity Office of Google. We have Professor Stephen Matlin. He's a visiting professor at the Institute of Global Health Innovation at the Imperial College London. And Santino Severoni is the director of the Health and Migration Program of WHO. So without further ado, I would like to leave the floor to the first panelist. I ask all the panelists to try to be very brief because, as you can see, we have a very large panel of 8 speakers. And we would like also to leave the floor at the end to all of you for questions and comments. So please start to reflect on possible questions because at the end we will open the floor to give the opportunity to some of you to intervene. So now it's a pleasure to leave the floor to the first speaker, Ozge Karadak.
Thank you so much, Professor Sasso. So I'm not sure, so this is working, I think. Okay. So thank you so much. I actually want to start with a brief introduction of why we wanted to focus on this topic. Because as you know, we all have some kind of barrier in accessing health information or services, including social determinants of health, language, our legal status, and other factors. But we all know that these factors are more prominent, or these barriers are higher for forcibly displaced populations. We wanted to focus on young people because we know that young people, especially young girls, stigmatized, marginalized youth groups, are among the most vulnerable when thinking about, again, forcibly displaced populations. And we know that in most of the forced migrants and forcibly displaced populations, the proportion of children and young people is usually higher than general populations. And we also know that innovative technologies offer great potential for improving health literacy and improving access to health care. But of course, we also need to consider digital divide, and we also need to consider barriers in accessing digital technologies, internet, which may not be accessible for all, especially in terms of gender. Today, in my talk, I briefly would like to talk about the importance of community participation and youth participation when we plan, implement, or evaluate digital health interventions. And as we know, community participation in health means that we involve individuals, communities in planning, implementation, or evaluation of health policies, practices, and research. And it's very critical to include disadvantaged populations in our work, because they can identify problems and solutions better, and they can tailor responses to the needs of diverse populations. And why we should involve young people in our research or digital health interventions, because we obviously want our research or health intervention to be culturally sensitive, youth-friendly, and to be based on the real needs of young people. And if we involve them to our work, and if they are actively engaged, then it also helps to raise awareness among young people about their own health problems and needs. It also increases acceptability of the research or intervention. It increases trust to the researchers or the project team. And it also helps with increasing the level of participation of young people in our health interventions. We better identify their motivations and barriers, especially if we want to change a health behavior, or if we want young people to utilize some kind of a service or digital tool. And I believe participation and involvement of young people also helps with increased control of young people over their own lives and health. And it empowers young people. They have better problem-solving skills, they have increased self-esteem, and they feel being valued when adults work with young people. And lastly, I think it also helps with improvement of social bonds and social resilience among young people. When we think about digital technologies, we can involve young people in our research, digital health research, by using, for instance, community participatory research approaches. We can include them in our advocacy efforts to inform future health policy making. We can involve them in co-design of digital health interventions. We can involve them in implementation of these interventions and also evaluation phases. And lastly, I would like to say that field experience of many research groups and scientific evidence from around the world show that youth participatory and co-design approaches increase the success rate of digital health interventions in multiple ways. Youth participation is even more effective if we also use peer-to-peer, like youth-to-youth approaches. For instance, training young people to act as digital health mediators or digital peer educators in reaching out to other young people or referring them to available health services. In summary, active engagement of young people ensures that we create tools that are youth-friendly and more sustainable in the long term. Thank you.
Thank you very much, Asge. And now it's a pleasure to invite Selma Karabey from the University of Istanbul to take the floor.
Thank you, Luciano. First of all, I would also like to thank you for your great effort in order to keep the migrant health in the agenda. Thank you for that. And ladies and gentlemen, I'm very happy to be here with you and to share our experience. Actually, Özge made my job easier, and so I'm gonna try to introduce the mobile application named Reach for Health. This app was developed as a component of REACH project. The long name of REACH project is Refugees Act and Communicate for Health. This project was carried out with the aim of increasing health literacy of refugee youth and, of course, local ones, and increasing their access to health services through the use of digital technology. It was carried out in Turkey, Lebanon, and Jordan between 2019 and 23. Executing agency was the Center for Sustainable Development, Earth Institute, Columbia University. Özge has worked at the center during the all project period. And local partners were Istanbul University, Biriz Association, which is an NGO working in the migrant mental health field, and also American University of Beirut from Lebanon, my dear colleague Nuhat, and Jordan German University from Jordan. Now I will shortly talk about the Turkish leg of the project. In the beginning, of course, comprehensive data was collected using a mixed method, including qualitative and quantitative techniques. With this study, we aimed to learn the thoughts and needs of Syrian youth living in Turkey about health, and also to get the thoughts and suggestions of service providers and decision makers on the subject. According to the findings of the survey, with more than 500 young refugees, despite the long duration of residence in Turkey, language problems and other barriers, unfortunately, in accessing health information and care still existed for refugee youth. And also the health literacy level was low. On the other hand, it's a good news, Internet was one of the most preferred resources for seeking health information, and almost all of them had the opportunity to get internet use. And also most of them have mobile phone. And when we asked, 8 of 10 refugee youth were interested in using the REACH application. These data show that reliable digital health tools have a huge potential to be used widely and to increase health literacy and healthcare access among refugee youth in Turkey. And then the mobile app named Reach for Health, as you see in slide, was developed entirely in close collaboration with project managers and young people, as Özge emphasized. It is a freely available app, and it has Android and iOS version. Again, the aim is to improve young people's health literacy and healthcare access via digital technologies. Reach for Health has 3 language options for Turkey. Turkish, as you see on the left image, there is Turkish, English, and Arabic options. Also local youth and English-speaking youth working or living in Turkey has also opportunity to benefit from this app. On the health topic section, the app enables access, my time. And also, health topic section, the young people can find many detailed and safe, secure health information about that. And also, there is a location showing some healthcare centers, etc. And there is another opportunity to ask the health mediators some questions about the health topics, and they can get the answers. Maybe I can go on the second tour, if I have, about the assessment and the challenges. Of course, nothing is pink, and so we have many challenges. If possible, I would.
Thank you very much.
Yeah. Thank you.
I see some people standing. There are still some seats here in the front if you want to come here. So thank you again, Selma. Now we move to Nuhad from the American University of Beirut. Thank you, Nuhad.
Thank you for making it. I'm happy to be here among you, and I would like to thank Oski and Professor Luciano. Taking it from Selma, so while we were disseminating the application, just to test it to pilot groups, to a few pilot groups, we found ourselves working on other initiatives where we wanted to really have the local and the refugee youth work together, because as we were preparing the baseline data, we discovered that the local youth in Lebanon, as probably all of you know, Lebanon not only had the highest proportion of Syrian refugees since 2011, sharing resources, but also we had the economic collapse in October 2019, and then the pandemic and the Beirut port blast. So all of these together devastated the country further, making it hard for local and refugee youth. And we know that we have Syrian refugees, but before we had Palestinian refugees as well, Iraqi refugees, and you name it. So we thought that this application will be helpful not only for the Syrian refugee youth, it will be helpful for all youth living in Lebanon. So as we were piloting the application with a few youth groups, I will share the story of 3 in underserved remote areas in Lebanon. 2 of them are at the borders with Syria. So we found out that these groups of 100 to 200 young Syrian and Lebanese who are competing over healthcare services, and sometimes there is animosity between them, that there should be something that we could do as healthcare professionals through the application. So we made them sit together and talk. It wasn't easy, it was hard. But the first entrance into making them talk is, what challenges do you face as a young adult or youth or adolescent in this country? So that they share same concerns, same challenges, and then identify that we all have same issues, and then decide that let's do something about it together within our underserved community. So we suggested that we're there to help, but we will not bring ideas that are designed outside, like most of the times in devastated or countries with disasters and catastrophes. Thanks to the international communities trying to help, but at the same time they bring their agenda into the country without really checking with the people who are suffering within the country, what is their perspective and how do they think it should be solved. So those youth groups, we trained them how to do the assessment. We built their capacity in assessing their communities, checking with key persons in the community, like the head of the municipality, the teachers, whoever is there, and then putting a list of problems that they think need attention and selecting those that are of priority but we can reasonably address. So it was done by them, for them, similar to the application by the youth. All the topics within the application were done by the youth, for the youth. So the 3 examples that I want to share with you, one group selected bullying among school children, but they wanted us to bring a specialist who is very well acquainted with the culture, the Lebanese Syrian culture, and who can do activity for the kids, but also for the parents. And we're continuing we're continuing our relationship with them. The second group selected and evaluated, we have only one river where they do rafting in Lebanon, in a highly populated, underserved area, at the borders of Syria. They selected pollution. They said, we're fed up of cleaning the river edges. We want something sustainable. We brought a local expert in recycling and remanufacturing whatever is available, and they are now pushing their municipality to adopt that idea. So it was by them, they identified the problem, they are leading, we are there only to facilitate. And the third group is kind of different from the rest of the 10 groups. There are 10 groups across Lebanon. The third group is selected the topic of why don't we in high schools or middle schools learn how to serve our community up front and be a mandatory thing? And in what ways can we serve? So what we did as a group is we brought NGOs and INGOs into a big area in their school to talk about how youth can participate, engage, and help in while volunteering for some activities. Actually, as we speak now, because we're expecting a hit on South Lebanon, those youth groups are being engaged and active in terms of getting blood, helping in opening finding places for the people who may be displaced, collecting food, collecting clothes, etc., etc. So through that application, that application opened the doors for many activities. Sorry, I'm about to cry. Open the doors for many activities, many initiatives to help the people, especially the underserved people. Thank you.
Thank you very much, Nuhat. And now we go ahead with Rabin from the Social Development Horizons in the U.S. Thank you.
Thank you all so much. First of all, many thanks to Professor Luciano, to Santino, and everybody else on the panel, and for all of you to giving this an importance because of how critical it is. As an Iraqi refugee and twice displaced, growing up under war, first of all, I can't start speaking without saying how my heart is really, truly with the people in the Middle East right now, and the victims on both sides, and the displacement that is bringing. And at the end of the day, it's the innocent civilians who suffer, and you see the breakdown of services, you see how much of communities and also the psychosocial toll that this is going to have on generations, and the trauma that is creating. And it reminds me of another tragic time, which was in the region where I'm from, when ISIS invaded Mosul at the end of 2014. And that was the impetus for me at the time to go back. And I want to share with you more of my personal story of that, to go back to Iraq and Iraqi Kurdistan region and start an incubator working with young entrepreneurs from the IDPs and the host communities, especially youth and women and young women and girls, to help them to start new enterprises and new innovations as a way to tackle the displacement and to tackle the despair and all the issues that were going on. You know, that experience for me, for one thing, having been a health professional for a decade prior, working with community health workers and community-based initiatives and health systems, prior to that time when ISIS invaded Mosul, I had no idea even what entrepreneurship was. I did not know what an incubator was or how much it could be related to health. But the experiences that we had showed that all the lessons that you can work with in creating engagements with communities and bringing different populations together to co-design their future truly transforms and and helps to bring people together and take a completely different aspect to their development of co-designing, of building a future for themselves at a time when things are falling apart, when bombs are falling, and when different communities have to be displaced. We ended up with a program starting in 2016 that was oversubscribed. It was provided for free. 1/3 of our participants and folks who came and or entrepreneurs were from displaced populations. 2/3 actually were women and girls, and I am super excited to talk about that, but also even more excited that I ran into a member of the audience by pure coincidence who is from Iraqi Kurdistan, Dr. Mustafa Kamal, who's sitting there with the audience, who happened to be one of our champions, and he's the only other second person that I know of. I'm sure there's many, but from the region where I come from, and that's a testament of entrepreneurs moving on, and in his case, being a part of the Ministry of Health and adding innovations to the healthcare system in the country. But moving back to that experience, the reason we went into it and some of the lessons we learned were, I would describe it across 3 areas. One was despair and hopelessness and lack of engagement is a true killer. And we know that in the health community. We know the effect of loneliness on elderly populations. We know the effect of mental health. We've seen that even more during COVID times. And this was pre-COVID. But it also has a humongous effect on communities. It has an effect on gender-based violence. It has effects on cyclical aspects of violence and fragility. And and not to mention economic growth. And you see that when you have conflict, whether it's due to when you have disasters, whether it's due to conflict or climate change, when things fall apart and people are in despair, whether they have already been displaced or whether it gives them the impetus to then want to leave the country, this is a huge issue. So what do we do about it? We reverse the narrative. And we made it about dreams and a vision. And that's where the name My E-Dream came from, because we wanted people to come and say, my entrepreneurial dream is to do something, as opposed to here's the problems that we're facing and everything is breaking down. Secondly, there is many amazing experiences and expertise around this panel that we're so lucky to hear from, that are working with engaging communities and co-working together. And one of the things at the very basic level of that is the ability to co-design and how much that truly brings different elements of society, whether it's displaced populations with host communities, whether it's across genders and economic backgrounds and ethnic backgrounds. And so we took the elements of human-centered design and design thinking, and we used that to bring people together to say, I want to solve this in my community. And some elements of that were broadly social determinants of health, and some elements of that were more economic engagement. But what that really did was pair up people from different backgrounds without any indication of where they came from, or the fact that this person came from that community or didn't speak English and was from an Arab community or Kurdish community or Yazidi or Christian or whatever it may be, women, man, whatever it may be. And we teamed them up in teams so they could go out and make these visions of their entrepreneurial dreams into projects, and we had a systematic approach to it. Of course, there was like hackathons and 2 months of incubation and mentorships and other elements. And the third thing is, if you want to have sustainability in situations like that, besides just one project or a one-off, we realize we have to invest in the ecosystem and then ecosystem creation. And for us, that kind of came down to kind of 3 Ps, as I like to call it: the people, the partnerships, as well as then the processes and the policies. My E-Dream is no longer active today. And I am really proud to say that, because the people were empowered to then go on and start up a movement. And, we see one of our champions here. Many others ended up in industry. Some ended up creating other entrepreneurship incubators and community-based organizations. And at a time we started, we were just the second incubator in Iraq and the only one in Iraqi Kurdistan region. Right now, there's 24, which is fantastic. And you just have to push the ecosystem and empower people and get yourself out of a business. The second thing in terms of partnerships, we didn't even design any of our own curriculum. We reached out to incubators and communities of practice, both in health and peer work networks, as well as in accelerators from UAE to Turkey to Israel to Pakistan, India, Washington, D.C., Silicon Valley, and all over Africa. And people donated material and mentorship to us. And what made that happen was the digital technologies that we used at the time. People could, this is before COVID, get online and take advantage of digital mentorship or come up with digital solutions so that they'd be able to advance that. And I want to get to that in the second part and speak about some of the specific stories that we'd be able to do. And last but not least, the policy environment and the ecosystem is so critical. Iraq, Kurdistan region, or even the Middle East, some better than others, are not famous for ease of doing business or good governance. And so there were huge barriers of registering initiatives, of people not having cards because they're displaced, and the requirements for capital. Fast forward. Right now, small and medium enterprises can register online. There's elements that even at the time we were talking about potentially putting on blockchain and things like that. And it took more than a village. It took an entire country to move it forward. Of course, World Bank was at the forefront, UN, civil society, the government itself. But these things happen, and they really transform the way that people come together. And at the basics of it, it really comes back to the idea of being able to bring people together so that what can you do about the current situation at hand? How can we take advantage of elements of healthy settings, of community-based initiatives, of all the things that we know in health, peer support networks, and we can apply that to create a vision for people and a co-working environment so that it moves them beyond all the elements of despair that they brought into it and brings the displaced communities and hosts together. So thank you so much. And then I'll look forward to give you a couple of the specific examples, and especially of our young women and girls who did phenomenal work as a part of that.
Thank you. So I've been told that Paul is not online yet. Maybe I also ask kindly Oscar to try to reach him. Again, it's very early for him, so it is also understandable. So we move with pleasure to Ivor Horn. She's, as we said, Director of the Health Equity Officer of Google.
Thank you. It is a poignant time to be having this conversation, and we know that forced migrations are growing increasingly, and vulnerable population, particularly youth and marginalized populations, are really impacted. And at Google, we really believe that information is a determinant of health. And as part of that work, we want to make sure that we are providing high quality, authoritative information, authoritative content. And I think we think about 3 areas that can really sort of support and provide health information and health promotion during these times. One is personal safety. The other is mental health that you've brought up. And then the other piece around community connectedness. And when we think about that, when we talk about information as in community connectedness, really putting patients and oftentimes youth voices at the front and center, making sure that we are creating community is important, and people want to be seen and heard. And so creating voices and making sure that we have videos that are personal stories around health information that is aligned with authoritative content. In the ways that we think about making sure that we are addressing misinformation, because oftentimes there's much greater risk when you're in mobility that you have misinformation in people. We learned a lot about this in the pandemic, and we want to make sure that any misinformation that doesn't address authoritative content related to prevention and prevention of disease, we want to make sure that that's removed and addressed. That goes against treatments that are identified and scientifically sound treatments, as well as anything that denies things that we know are accurate and authoritative information. So those are areas where we think, and particularly in the work that we do at YouTube, to make sure that we are not perpetuating misinformation as part of that work. The other thing is thinking about how do we expand equitable access and equitable information. We have a program called IQ Creators, and this is really to increase the voices that are out there and more diverse voices as part of the creator community, and that includes health professionals from diverse backgrounds to meet people where they are with content and information. And another project that we're working on now is it's called Aloud, and basically we're collaborating with some creators that allows active dubbing of their content in the moment, so that in various languages. So that's one of the areas where we're thinking about how do we not only create voices but expand those voices and expand access to that information so that people feel seen and heard. One of the things that our team, one of our Jigsaw team did a debunking campaign, and basically it was really to fight narratives that were scapegoating refugees during the as part of the Ukrainian refugees. So those abilities to think about how can we support and contribute to make sure that we're reducing misinformation. The other one is around personal safety, and this is an opportunity, a couple of areas that we work with. One is around flood forecasting, and we use AI technology to try to identify flood forecasting, and then crisis response tools that you have on your Android phone that can help identify and tracking of wildfires, as well as being able to identify earthquakes and to create alerts on the phone for that. We often get those in California, so we use that as well. The last thing, the other pieces that I wanted to talk about is one around protecting location history. Location history is off by default. And then in some areas where people can have the ability to delete their location history when there are issues of not safe, we want to make sure that for the LGBTQ plus community that we're creating spaces that are safe and belonging. We've partnered with GLAAD to make sure that we have representation and representative photos as part of our work there. And two more things that I'll talk about is one is around Open Health Stack. You talked a bit about entrepreneurs and innovation. Open Health Stack is a tool that we use that allows for creating authoritative content that's fire standard and HL7, and it puts the tools into the hands of entrepreneurs who are on the ground, who are creating content to make sure that they're using appropriate SMART guidelines and clinical guidelines as part of that work, but it allows them to create it in a way and putting it in the hands of community health workers where they can bring that information, and it can be used offline to help address some of the access issues and uploaded when there's access to Wi-Fi. And lastly, I want to talk about, I'm a pediatrician by training, and the importance of really making sure that teens and children, young children, have a safe space online and safe experiences online, and that's part of the work that we do. So all of these areas of creating community connectedness, creating personal safety, and making sure that when people come and they have mental health information, they have access to that information. We expanded our content on mental health to Spanish language and continue to work to do that expansion to other languages as we move forward. So it's a humbling place to be in, to say we have resources and tools, and we want to make sure that as the more we do, the more that we create resources and tools for those who need it the most.
Thank you. Thank you, Ivor. And now we move to Stephen Matlin from Imperial College London.
Thank you, Luciano. I'd like to summarize some key points from a review that I'm currently working on in collaboration with Joanna Hannefeld, Luciano, and others involved in the M8 Alliance expert meeting on migration and refugee health, in which we looked at and examined the use of digital solutions. And as we've been hearing from all the speakers so far this morning, it's very evident that digital technologies can play many very valuable roles in supporting health and health-seeking behaviours of migrants, refugees and forcibly displaced persons. And it can also facilitate research on their health issues. And we've heard many examples of this from other speakers, so I'm not going to dwell on that, but rather we've also heard some of the challenges and issues involved and some of the vulnerabilities involved. And I thought it would be useful to kind of collect those together and make sure that we do have them in mind, because some of the particular challenges and risks that are present, as well as opportunities, need to take account of the fact that migrants, refugees and forcibly displaced persons do have more constrictions and do have more vulnerabilities than the general population. So there are just two general points that I want to make and then give a few examples in each case. And first of all, it's important to recognise that digital technologies are not a panacea. There are particular challenges, limitations and questions, of which I will just briefly highlight 5 today. First of all, the question of ensuring the security and confidentiality of information on the individual, which includes not only the person's identity and their health matters and issues, but also their physical location. And as we've just heard from Iva, one of the important things is to ensure that they can't be tracked, as it were, on their own phone through their location history. But records that are created and held by others about them may contain that information as well. And this is a critical factor for the survival of people in some cases. And then there are ethical issues, and I would particularly mention include the meaning of informed consent and of freedom of choice. Thirdly, we've heard about the need for engagement of migrants and displaced persons themselves in the processes of designing, implementing and researching digital tools. And we need to be aware also of the vulnerabilities and the constraints that are involved in those. Then there's the challenge of access to mobile telephony and the internet, including a whole range of factors, including legal constraints, local and international connectivity, the portability of data and especially of health data, equity in access, and then there are the costs, both the financial and the opportunity costs for the migrant. And then there's the question of access to health services for follow-up when health issues are identified. So it's important to recognise, as my second general point, that digital tools provide most immediately technical solutions, and they do not necessarily overcome problems that are political, social, or economic in nature. They may indeed be able to help, and we've heard a couple of very heartwarming examples from panelists this morning about how, for example, providing an interface between people in displaced situations and in the local communities can lead to better understanding and can help to ease a range of social issues, and also how this can impact in areas like entrepreneurship. But we need to be aware that there are cases when these contacts and issues may exacerbate problems. And for example, they may accentuate social inequalities and the gender divide in access to mobile phones. And there may be additional opportunity costs for the migrants in various ways, including the use or abuse of digital technologies by states for control and surveillance of migration, and including policing irregular migration. There may also be abuse by individuals who want to use the mobile technologies in order to gain access to individuals who are vulnerable and use the process for extortion, blackmail, coercion, and so on. Consequently, it can be concluded that a comprehensive socio-technical perspective is needed in designing, implementing, and evaluating digital solutions for migrant and refugee health, recognising the vulnerabilities and risks as well as the opportunities. In the work we've been doing, we have drawn on perspectives from 3 intersecting frameworks, and these are, first of all, the health determinants framework, including biological and social determinants, and recognising that migration itself is a determinant of health. Secondly, the structural factors framework, which includes rights, governance, policy, and practice aspects. And the third framework is the human security framework, which is broadly described as freedom from want and fear and freedom to live in dignity, and which includes economic, environmental, food, health, political, personal, and community dimensions. So we found that taking these three frameworks together provides a very broad, multidimensional basis for looking at migrants and refugees and displaced persons and seeing whether health technologies are appropriate for them and whether they provide the necessary protections. And we find that this can be a helpful approach in meeting the challenge of digital solutions for the health of these very vulnerable people. Thank you.
Thank you, Stephen. And now, last but not least, I give the floor to Dr. Severoni from WHO.
Thank you, Luciano, and allow me to start by joining Professor Selma and thank you for keeping high in the agenda of the summit the topic of health and migration through different angles, but every year there is an appointment here for us to discuss about health and migration. Thank you very much for that. The task you assign me is to try to sum up and to collect also outstanding challenges or unresolved challenges for the health sector where we need to pay attention. And I put together 4 points which actually are perfectly mirroring the sharing we heard today from our colleagues in different experiences in different countries. Well, the first point is reaffirming the fact, now this is a reality, and we have evidence about that digital innovation is recognized to be an opportunity to achieve health for all, and particularly in relation of achieving universal coverage. However, there is a but, remain pretty inconstant the application. Still there is a lot of work to be done, and the application, utilization of digital technology and innovation remain untapped in many settings, particularly in the health sector. And we see a big divide in equity between countries in different areas of the world, but also within the same country in many aspects. In terms of global landscape and policy framework, the digitalization, the digital health, that's how we call it in our environment, in WHO. This is on top of the agenda of work with member states in the last 20 years, 2 decades, roughly, with the objective to really accelerate the achievement of national and global target and altogether to contribute to the achievement of health-related SDG goals. Reality is that our monitoring shows that we are actually far from achieving the SDG 3 today. There is a lot of recognized to COVID, but the objective, the target we posed a few years ago are obviously showing to be unmet at the status of art we are today. So certainly more need to be done, and probably digitalization is one element that can play a very important role in accelerating. We have a global strategy, 20 to 2025, so we are in the middle of implementation, and among different priorities of action of the strategy, the most important is really to bring up the engagement of the community, the engagement of people, making them participate into the shaping up of the health systems and services that they need to be used. We recognize this not to be a routine approach in the health sector normally. This becomes even more complicated in the case of migrants, refugees, and then if we go to the vulnerable group, into the migrants, refugees like children, women, the situation becoming even more complicated and concerning. The second point, and there was quite a lot of information about that, is related to the risk that this innovation also can bear with it some concern or potentiality in exacerbating inequalities. And this can manifest through different aspects, but what came up more consistently is disinformation, digital poverty and exclusion, and management of privacy and data. These remain in the health sector still a big issue, the governance of data. There is a lot of discussion, a lot of effort, but still we are concerned about that. And if we are applying this let's say, transparent, this matrix to the reality of migration and migrants and health of migrants. For example, during COVID, we really had the demonstration that when we step into the rolling out access to immunization to COVID-19 vaccines, digitalization became a very painful aspect in driving misinformation. We invented terminology of infodemic to explain the overwhelming amount of information, many of them not grounded by evidence or not real, or exactly with intention to disinform. Digital poverty and digital exclusion remain a fact that the world is really governed by inequity, differences between global north and global south. And even in same countries, between urban and rural area, we see a big divide in terms of quality of service offer, the way how the systems are functioning and access to the system made available, but also in certain countries, the access to device. There are some interesting initiatives. There were some times ago in India an initiative to make iPad affordable to students, so really cheap, at the cost of $25 for an iPad, in order to accelerate digitalization and education in the rural area. But those are remaining sporadic initiative or really specific country initiative. Data privacy violation, especially when we go to migrants or forcibly displaced migrants or irregular migrants, this is becoming a big issue, because still we are observing countries where the utilization of health data are utilized to manage migration. Still there is not a firewall between the data collection, usage and custody between health sector and interior, police or migrant management. So there is still a very porous, very open space for utilization of specific health data, which is supposed to be protected above anything else, if we are responding and acting animated by the principle of right to health, so protecting this important right for the entire population. And this is particularly true during the migratory process, in many cases with very positive intention to register the individual who are migrating in order to initiate process of asylum protection or reception in a country, but those data really keep posing important concern in terms of how they are used and how they are impacting then in really limiting the access to healthcare. Again, during COVID, we ran a survey. We interviewed 30,000 people around the world, and it appeared that one of the main concern for those migrants, forcibly displaced, irregular migrants, so those more vulnerable, to refer to healthcare system was hampered by the fear of deportation as a first concern. So data could be used for this purpose. And then the health cost associated, so the difficulty to access the health services, so the digitalization actually not yet helping to reduce cost in terms of accessing data. Then there was a very important testimony and contribution in relation to equity and digital technologies. Clear, strong reference to issue of gender and divide between North and South, but more important, I like to underline the factor that every time we are launching digitalization initiative, we're supposed to assess and protect and pay attention to factor triggering inequalities, triggering misuse of those innovation and facility. The issue of gender in the area of forced migration or irregular migration, we are particularly concerned because we see that abuses, sexual-based violence, gender-based violence are unfortunately the routine, especially in certain contexts. Before there was reference to Central Mediterranean migration, you need to understand that those finally get in a boat to migrate irregularly towards Europe, they are probably coming from 1 year, 2 years of perilous journey from their own country of origin through different countries and experiencing detention, experiencing all sorts of difficulties. Imagine that in many cases, the availability of drugs, having some drugs in the pocket, this is used as a currency to get protection and to get help in proceeding the journey. Sexual exploitation is a trade exchange. Usually the migrant woman making herself available to sexual exploitation is a sort of way to get a protection during the process. So we are experiencing unwanted pregnancy, we are experiencing a lot of problems related to that. So the not only utilization of digitalization data, but also the ability to detect those situations and data supposed to be the starting point to indicate to migrants a needed process for receiving health care, this is not yet there. So there is a disconnect of collecting data and real actually access to health services and health support. There was made reference to mental health, and we are also experiencing a growing population of unaccompanied children because this is easier for family to start the migration process, and those are really the group we are more concerned. Last but not least, there was an allusion from Professor Metlin to research. This is a really important point for us. It's very, very dear to us because we believe that innovation or any action we are requesting to member states to implement in order to improve the health systems setting supposed to be supported by strong evidence, by strong research, by fact. It's very difficult to meet politicians, Ministry of Health, and to convince them on a change, investing maybe resources, allocating human resources to new services if there is not really a gain in terms of economic element and sustainability, but also in terms of political decision and opportunity that this is more convenient. So this is extremely important to invest into research and also to analyze, to dissect, to evaluate existing initiatives. Now we are observing really a flourishing of a number of initiatives worldwide in relation to digitalization in the health sector. Those must to be evaluated, must to be dissected, and if it's possible, recomposed into toolkit packages that can be offered to other countries to not to go through the same process, but to have a faster process of learning and application. The other element, this is also important, the evaluation and the understanding of the context where the initiative are launched, because as I mentioned before, there is a big divide between north and south of the world. So while implementation of innovation and digitalization is quite easy in high-income countries, this cannot be taken and replicated blindly in a low or middle income setting, but we need to understand the context, we need to understand the impact, we need to understand what are the needs and the priority. In this regard, and we were also very pleased, I was discussing before with Professor, we are preparing the launching of the first WHO research agenda. We're going to launch this on the 30th of October, and we went through a quite intense process of consultation and discussion with different experts and academic institutions. And it was interesting to see that one element of concern for research and priority for research was raised in relation to digitalization. And actually, I'm quoting what was recommended in the consultation to invest into research on digital solutions for enhanced access to healthcare, for example, but not limited to digital recourse, telehealth, digital literacy. So this is I think we can do much more in documenting what we are doing well, in evaluating what we are doing well, but also investing into research to fill gaps and to show what is functioning or not. Thank you so much.
Thank you. Thank you very much, Santino. I know that Paul is online now. I asked the technical assistant to check the waiting room, the virtual waiting room, because I know that he's online. We can try to have him. In the meantime, I ask the audience to prepare some questions or comments, because we will open the floor shortly for all of you. Do you see him? Perfect. Okay, great. Thank you, Paul. Can you hear us?
Yes.
Hello, Paul. Yes, thank you for waking up so early for us. Thank you. The floor is yours.
Whoa, that was quick.
Yeah.
Thank you.
Because we are
Thank you.
almost at the end of the session. So this is the because it's already 12 here. So I think that maybe there was a problem with the time zone. They already did 1 hour of the session. I think there was a problem with. That's okay.
Oh my goodness.
I will use my Mediterranean flexibility to
Oh
to
my
make
goodness.
this big
I'm so
change.
sorry, everyone.
No
That
problem.
was
No
my
problem.
fault.
You have the floor. So we had some interventions already. So you are the last one to intervene, and then we will open the floor
Okay.
for some questions. But you know the topic very well, so I think there is no problem.
Okay. Firstly, I'm so sorry, and I apologize. Time zone must have got me, but I don't know why, because I'm used to that time zone. But anyways, thank you, everyone. And I will, because I don't know what was said previously, I hope I will not repeat myself. But what I would like to talk about really now is the potential use of technology, and also some of the challenges in using technology. And I'd like to think about my recent experience responding with the Ukrainian refugees when I was based in Poland for WHO. There were a couple different areas. Number one is personal health records or personal medical records. And it would incredibly improve our efficiency and effectiveness of response if people were able to have their own agency over their records through the cloud. And then we had different systems that could talk to one another. What's interesting, this is not new, but it's never occurred. And what's interesting is that the technology actually exists, but it's more protection issues that are really causing us not to move forward on this. And it's both concerns about data protection, concerns about data going across border. But this is one instance, unlike the other two that I will speak about, where it is feasible to do. So it's rather a will of bureaucracy and administration. The second component related to Ukraine, but it's for every emergency, is trying to find people, particularly when they're moving across borders or within a country, and they're mixed in with the host populations. There now is enough technology to be able to try to follow people. The problem is it's incredibly biased, and so we would need a multitude of different technologies, everything from satellite data, social media, crowdsourcing, cell phone towers, shelter and shelter occupancy, changes in rates of shelter to try to know where people are. Some of this is possible, but again, others, because we would have to deal with private companies, this may be problematic in terms of getting access, particularly cell phone data. And then finally, because I don't want to take time because I'm so late, is artificial intelligence and trying to use big data to be able to have an idea and predict population movement, the demographics of the population, and the epidemiological disease profile. And the problem that we're running into there is that the data for machine learning to really do well, you need large sets of data that are very, very good and high quality. And obviously, what we have is not generally the case. So we have a limited data, and it's a bit piecemeal. So we hope, and we're starting to work on this, to be able to examine all the various data sets, to be able also then to look at health outcomes, whether it be acute malnutrition rate, mortality rates, and then try to be able to use machine learning to be able to see what has happened in the past, and then to be able to predict, at least in what is predictable, because there's many unpredictable components in terms of displacement, of how this can be used. And I'll end by just saying that it's obviously very important. This is about youth, and the availability and the way that the youth are able to use technology will continue to grow, and therefore I'm hopeful that a lot of what I'm talking about, whether it be personal health records, whether it be data estimation, data movement, and ultimately data prediction, we'll be able to see this come true with this next generation. I'll stop there, and again, sincere apologies for mixing up the time zone.
No. Thank you. Thank you very much, Paul. No problem for the delay. Maybe it was our fault. We should have told you exactly. The thing there is a different in the time zone during the summer and the winter. Maybe that was the problem. So it's actually we have less than 30 minutes, and actually we don't have time to do a full second round as we thought. In the beginning, as Italian in Germany, I'm very concerned about keeping the time, so I want to finish exactly at 12:30. So let's open the floor now to all of you for questions or comments, and then at the end, if we have time, we do a very quick final round with the panelists. Please raise your hand very clearly. We have so many already, so that's a challenge. I will try to go a bit randomly, maybe here with this lady in the front, and then it will be difficult to accept all but try to be very quick in posing the question, and then please very short answers, and please state your name and affiliations and to whom you address the question, if there is a specific panelist.
Okay, thank you. My name is Jade Mason. I'm a senior fellow at the Global Health Security Fund. In the last 2 years, I've been working at WHO in Geneva. A quick question. The panel discussion, I think the main word that made me want to come today was youth health. And I think our first panelist and the first few panelists spoke a lot about, it's very evidence-based that involving youth and communities in digital innovations and health interventions is only going to make them more successful. And I'm just wondering why there's no young people on the panel. And that was kind of my main disappointment as I sat down, and that is my question. And I guess it's directed to everyone on the panel, but maybe the first three or so speakers who seemed to touch on it. Thank you.
Thank you. We are spiritually very young. We feel very...
I subscribe.
Maybe one of you, if you want to, maybe Oscar, you want, very quickly, please, and then we move on, because we have a lot of hands up.
Yeah, I mean, in our own projects with young people, we actually did involve them in all stages, including planning and planning of both research and co-design approaches, and then implementation and evaluation. And we worked with them during dissemination of our findings and experiences and, advocacy, etc., at the local level. But since this was an international meeting, and because of economic and visa-related reasons, it's kind of barrier, especially for young people from the region, to attend the meetings. It wasn't impossible, but it was more difficult. But it's totally financial and, bureaucratic reasons why there's no young person, although they were with us and they're still with us in the countries, in all our meetings, in our visits to the Ministry of Health, in all dissemination and evaluation efforts, and in our publications as well. Now we are working with refugee and local young people to publish as well.
Thank you. If you can raise again your hands, let me see. Maybe the lady over there in the back. Yeah. Sorry, we try to random. I hope we will manage to take all the questions. Please go ahead.
Hi, so I'm Doris. I'm from the International Federation of Medical Students Association. As we've heard today, I know digital health has become a key part of our society with its wonders and also hardships. Medical students around the world have seen that digital solutions can cause psychological distress within their communities locally and nationally. How and when within the developmental phases should mental health professionals be integrated into the development of digital technologies in order to care for everyone's well-being? So, specific answers. Thank you.
To whom are you addressing?
Overall, I think.
Who wants to answer to this? Maybe Noah? Yeah.
I can give an example of how we address mental health. So in the design of our application, there are links to other applications. For instance, one that serves sexual reproductive health, etc. For instance, in Lebanon, yesterday actually, there was one presentation that talked about it. So there is this application on mental health where within it is an intervention. It is adopted by the Ministry of Health and in consultation with experts locally and internationally. So our application links to that mental health. And in the frequently asked questions, mediators refer to the leaders to get expert perspective to answer the question if the question is about any topic, including mental health. This is what we could do. I know that we can be short of having a youth with us presenting next time, maybe through Zoom if there are financial and visa issues. But again, one of the challenges that we faced is because we work with migrants and refugees, is that sometimes you want to do things to the best of your abilities. In mental health, there are cultural issues that they are a challenge, but at the same time, at an opportunity when in the baseline data we're collecting to develop the application, the youth and the adolescents, because the age group was 15 to 24, specifically mentioned mental health as a high need to be included in the application, in addition to sexual reproductive health and the gender differences. Thank you.
Thank you. So let's go here maybe to this gentleman, please.
Hello to all panelists. My name is Harpreet Singh and I am doing Masters in International Health Management here in Berlin. And my question is regarding the professional migration, like the professionals, the doctors and the pharmacists who are migrated from their own countries to others, but nobody is taking this as seriously. Because you all are talking about the forced migration setting, how can you make it complete if your own country don't have the health workers? So this is the biggest challenge for you. Like here in Europe, because nowadays Europe is mostly vulnerable to the migration, like the Italy, but I didn't saw anyone from the Germany who can represent here, because there is a biggest language barrier here also. Like I have a 14 years of experience. I speak 7 languages. I worked in Middle East. Because first you have to give us a responsibility, then we can learn the language. But here the challenge is language first, then the responsibility. So it is like for us, you are forcing us to go to UK to USA. That's why health workers definitely go to there. So this is a challenge for you to tackling this forced migration setting.
Thank you. I think it's more like a comment. Unfortunately, there are some difficulties. We will try to improve. I think next to you also there was another question from the other colleague next to you, or you changed your mind? I think you wanted to ask. Yeah, remember. My memory is still even not very young, but I still remember.
Thank you. It's John Reynolds, International Nepal Fellowship, working solely in Nepal, particularly rural areas. This is for Selma. Whilst you were speaking, I downloaded your app, and I've had a little look at it as I've been speaking. How is it possible for that technology to be available for other countries, other languages? The Nepali language is very, very different. The script is very different. But it's a good start point. And why reinvent the wheel?
Okay. Thank you for your question and comment, actually. Yes, we had some ideas to make it common and widespread. Maybe Özge can say something about it. Yeah, we have some ideas about it.
Thank you so much. So actually, I mean, if we had time, we also wanted to talk about the challenges that we experience, especially for adapting the application to other settings and for other languages. I mean, definitely that is possible. We actually used the same application, the same software, let's say, to work in Turkey, Lebanon, Jordan in different languages and with different contents. We adapted this application to 3 countries, mapping services in each country, working with different youth groups in each country, and with different languages. And it's possible to adapt it to other settings as well. But there are obviously some IT-related, software-related challenges that we are currently experiencing. I just want to point out, maybe because we are all health professionals here, we were not experienced with the IT and software part. And it's not always easy to understand who can, help with the IT part in the best way, because we don't know that field. That's why, that's maybe a lesson learned for us. Now, with the current application, it's not possible to have more content or another country, but we need to build a back end to be able to increase the storage, data storage capacity, and to involve more countries. And that needs funding, obviously, but we also learned a lot actually during our project, and we are now writing all these challenges and lessons learned for other colleagues, at least health professionals, to not to repeat the same mistakes or to do things in a better way, let's say. But in summary, we need more funding and more software support to be able to adapt it to other settings.
Thank you, Oscar.
You're
I see
welcome.
a lot of other questions. Let's go in the back, and the last colleague there.
Thank you. My name is Monika Cristofori. I'm from the Swiss Red Cross, and my question, I'm sorry, is again also addressed to the two of you, because you said your app was from 2019 to 2023. And I think we're all aware that there are tons of apps out there, but we hardly get any results on outcomes. And really, I would like to hear more about really health outcomes and also health literacy outcomes in the population. What have you actually what are the improvements? And I really like to hear statistics, numbers, not only, yes, we improved somehow. So,
Okay.
So, please.
Maybe in a short summary, I can say that while co-designing the application, we also thought about the evaluation and impact assessment. So what we did was we did pre-post surveys just before young people started using the first version of the application. We administered health literacy scales and the questionnaire to understand their access to healthcare, etc. And then they downloaded the application, and we followed those young people for 3-4 months to understand their user experiences and to see, obviously it's a short time to see a real improvement in health literacy, but we did reach out to the same people and again administered the same health literacy scales and try to understand with questionnaires, surveys, if their access to health information and services increased. So what we saw in that short period was, there was little improvement in health literacy, although it was significant. But the more positive side was their awareness about available services around them increased, and their user experiences were very positive. We also did focus group discussions with the app users to understand their experiences in a more qualitative way. And all the feedback was very positive, especially because we trained digital health mediators to support the application itself. So the users could reach out to those digital health mediators to ask questions and to know more about the services available to them. I think that human component and youth-to-youth approach was important. It was not just a digital tool, but there was young people supporting the application behind. And And I think that human component was important in the experience.
Thank you. Thank you.
The other
Very
potential
quickly.
could be, and here we're still exploring it, if we can, with the use of artificial intelligence and the geolocations, if those youth who used the application reached out to the primary healthcare center, in our case in Lebanon, for health services. This is still under discussion, knowing the infrastructure in the country and what's happening, but this is a potential for assessing the outcomes.
Thank you. Unfortunately, there is no time for other questions. I would like to do a final round with the speakers in reverse order. I would like to ask Paul, maybe in 1 minute, to try to give us a bit more feedback from you, and also maybe other information if you wish, but in a very short time.
Sure. Because I wasn't able to hear everything else, I would add that yes, we should have had a youth on the panel, absolutely. But I would add that I think if the institutions and the organizations and the private sector get together and address some of the key issues in terms of security and data protection, we can go a long way towards, even right now, using the data and moving towards artificial intelligence. But if we don't do that, the barriers are going to exist. I'll stop there. Thank you.
Perfect. Thank you, Paul. Santino, please, would you like to give us?
Well, I would like to reinforce the message for the sake of protecting the right to health is important. It's paramount important that government implementing a firewall separation between data management related to migratory process and migration information and health data. The health data should not be used for other purpose than for health, not for managing migration.
Thank you. Santino, please, Stephen.
Thank you. Very quickly, I'd like to just pick up on 2 points. One regarding research, which I think it's been said is an extremely important part. Unfortunately, it's one of the most poorly resourced parts of a very under-resourced field generally. And we've seen how it's critical both to know the immediate outcomes and later on the impacts of what's being done, but also to sit back from that and actually ask what should be done. And I think it's extremely important that we've heard that there is a new research agenda about to be launched by WHO, which will help to define and depict that. Secondly, within all of the areas that are neglected on the service side, mental health has been highlighted as one that's particularly important. And as always, as is the case in most societies in general, it's a very underserved and under-resourced area. I'd just like to mention as an example of what can be done that I'm the trustee of a UK-based charity called Children and War UK, whose purpose is to try to help children who've experienced trauma due to conflicts, wars, disasters, and other traumatic activities. And it does so through a cascade model in which tools have been developed which can help children to overcome their traumas and to recover into normal lives. And these are being taught through the internet, through the training of trainers in a cascade model. This has been applied extensively recently in the Ukraine and has been very helpful there.
Thank you, Stephen. Ivor, please.
Yeah, no, thank you. I think I'll start by saying we should have youth on the panel. We are learning in this process, and change comes from people speaking forward. So continue to do that. As a physician who works with youth, and has worked with youth, I think it is vital that we have all those voices, and I think for being here, for having lived experience, because that is also really important in these voices that need to be heard. One of the things that we really talk about is evidence and research and the research generation, and time is of the essence. We really need to move from evidence to action to scale. And so when I mean, I'm an academic researcher by training, so that is where I spent the majority of my professional career. in doing this equity work and realizing that it is woefully underfunded in every shape and form that the study goes, whether it's gender identity, forced migration, or racial and ethnic disparities at all of those intersections. So making sure that we're taking this information and connecting these communities of technology and research and public and private and civic organizations so that the information that we gain does not sit and go looking for a journal to be published in, but can take the evidence and what we know is working, move it into action, and not let it stay at the pilot stage, but move it to scale so that those lessons learned can be passed on quickly where we know that it is needed and iterated on and improved upon. And that's where, quite honestly, entrepreneurs play an important role, who have that lived experience on the ground is really important. So for my takeaway is, let's not continue to work in silos, and let's find ways to partner so that we can bring all of the skills and expertise that are in the room together to move things forward faster.
Ivor or Rabin, please.
Yes. And give you a couple of examples of our engaging young people, and as well as the equity and the importance of engaging women. One of our first-year champions had come from a community right outside of Mosul. His house was completely destroyed. He was a genius. They had rounded up all his books and burnt them. Fast forward, this young gentleman who did not speak a word of English had learned like 3 programming languages, and I don't understand these. You probably would do more, and come up with an augmented reality game and gamification that we were able to also try to work with to incorporate health elements and health education. And there's a critical element of that we don't have time to touch on, but gamification and adding health education to that, and augmented reality games and how that could be utilized, because you can't just go to a community that is in despair and just say, here's health education. You have to make it relevant for them, and that's another way to tackle infodemics. The second thing is, and I cannot stress this enough, but when the program happened, it was in the national news, it was in international news, and people came to us saying, how do you have so many women? And I said, well, it's pretty simple. You open the doors, don't discriminate, and don't make the men design everything for other men. Like when you engage them and you open, people will come. And 80%, 4 out of 5 of our champions in the first year were young women. And one of the second prize winners, she came from a farming family, socially conservative, religiously conservative. Her father would come with her in the trainings in the beginning because was worried about what we'd be talking about. It's in English. It was in the evening because so people could work or go to school in the mornings. And she said, I want to do something about every year we send our crop to the government silos, and about 70% of it gets lost because of waste, because of waiting in the supply chain, and et cetera, et cetera. And she said, I'm going to create an app to solve that. And, fast forward, we work with them and we, send them out to the community so they could figure out that not everybody can do an app, but how we can figure out text message interfaces with the app that you're designing. But at the end, her father came to the championship that we had, and he asked to speak, which frankly petrified me at first. And I got up there, and the man was totally in tears and said, what this program has been able to do, not just for my daughter, but for me, is I see my daughter in a completely different light, is that she provided solutions. Like, you look at these families and you see that sometimes they take out their daughters from school so they could work on a farm or work for the father, and here is a daughter who proved that she could actually create solutions and be the one that could completely transform not just a family business, not just the status of her and her family with other people in the community, but frankly, an entire economy. And all of these things are examples that come out of youth and women entrepreneurs on the ground in engaging these IDPs and host communities.
Thank you, Rabin. And Nuhat, please.
So hard to talk after Rabin's story. Just one recommendation is that we've experienced with our application when we were talking to UNFPA to help funding the maintenance of the application. We discovered that WHO in Lebanon, UNFPA, UNICEF, UNHCR have created applications about locations of health centers, primary or pediatric, etc., with not one of them knowing what the other is doing. So we were the one who discovered and put them on the same table, hoping that we will coordinate together. Lack of coordination really hinders us from moving forward. So this is a very urgent matter to progress. Thank you.
Selma, please.
Okay, also shortly, I would like to talk about some challenges. The biggest challenge, I think, the issue of sustainability for such project like us. For instance, our project doesn't have any financial resource, and therefore the app has not been updated for a while. Also, but we need it, and also content up-to-dating is very important. You know, the young people needs to have fun. And so making something fun requires some resources, and also it would be a challenge. And working with too many partners sometimes would be a challenge. For instance, in this project, we are working with many academies, NGOs, youth groups, IT companies, etc. This may be a challenge. And lastly, of course, technology, digital technology by itself is not a magical solution. Structural determinants, social determinants of health are highly important. And so maybe digital technologies can improve, can help something, can help to solve something, but it wouldn't a solely a solution for that. Thank you.
Thank you. Thank you. Oscar?
I just wanted to add that although we are discussing digital technologies and how it can help with health promotion among forcibly displaced populations and young people, we obviously as health professionals also need to think about the internet and digital technology addiction side. So we actually had difficulties in finding the right balance. Like finding something which young people can be engaged and use, but at the same time not to be addicted and do something outside. So when thinking about digital technologies, I think we should also think about the real life side, and in health promotion we should also make sure that it's integrated. These technologies are integrated with real life health promotion activities like physical activity, etc., or other things in real life, so that it's not the only solution, but an integrated solution with real life things.
Thank you. Oscar, unfortunately, we need to end the session now. We'd like to thank very much the World Health Summit team for the great support, especially Julian Kickbush. I would like to thank the technical assistants, really always very efficient over there with the green badges, they're really fantastic. Thanks to all of you for participating, for being so active, for posing so many interesting questions. Sorry there was no time to answer all the questions. I would like to thank very much Ozge Karadak, because she helped me a lot for the organizing this session. All the panelists, and especially Paul for again being with us online from the US. And please join me in thanking them very much.